And while I'm talking about what we should take, I think I should also mention what should not be taken. Most important thing is alcohol. Okay, that is deleterious for both of these conditions. And of course, smoking. So I don't know if that's part of diet or part of lifestyle. But yeah, it should be avoided. Yeah. Hello, namaste, salam alaikum, sat sri akal. Dr. Naeem Sadiq, neurologist, neuropsychiatrist, founder and director of Plexus Neuro and Stem Cell Research Center.
Welcome to the Dr. Brainstem podcast, your portal to the intricacies of neurodegenerative diseases. Today, with Plexus, we delve into the early signs, profound impacts, and cutting-edge advancements in the treatment of Parkinson's and dementia. We're dedicated to elevating awareness and deepening understanding of how these conditions affect both patients and their families. Guiding us through today's discussion is Ms. Kanishka, a seasoned occupational therapist with a master's in occupational therapy and the head of the Department of Rehabilitation.
So today we're going to talk about Parkinson's disease and dementia. So to begin with, we would like to know what are the early signs and symptoms of Parkinson's disease.
Well, Parkinson's is a disease where the onset might be very slow, and initially for quite some time, that sometime could be years together, symptoms may not be noticed at all. Symptoms will be typically in the form of slowness, which in medical language we describe as bradykinesia, where everything becomes slow. Then the second classical symptom, which is found in most of the patients, are the tremors. And the tremors in Parkinson are the typical tremors which are known as the pill rolling movements, very, very slow tremors, and which are there at rest. When a person is just resting, not doing anything, then you will notice the tremors. The person that starts doing some work, the tremors disappear. So they're so subtle, you might just consider them as, a sign of anxiety, or you might think it's because of fatigue, or, you're just tired, or things like that. Then the other classical symptom of Parkinson is rigidity or stiffness, where people find stiffness in the neck, in the limbs, in the trunk, and overall, in the body. And even this initially may not look as a disease. So typically these are the things which are found.
Okay, you mentioned about slowness. So can you talk a little bit more about what exactly is this slowness? Like, you just become slow? What is it like?
See, slowness is basically, it is a motor slowdown. Something similar to when you're playing a movie or something. You go on a slow motion mode. You see, everything is happening slow. Like for instance, now, normally you take it, cup and drink your tea this way. Now, in case of Parkinson, then the entire thing, goes, this is a kind of thing. Walking, the person generally becomes stooped, and each step he has to make an effort to take and then walk. Sitting down on a chair, getting up from the bed, every single thing becomes slow. In fact, even the speech might become slow. The normal, the way a person speaks may not be there. The volume goes down, the intonation may disappear. So overall, the movement becomes slow. Bradykinesia.
So overall, the person becomes slow. Everything about the person becomes slow.
Everything, yeah.
Okay, what about expressions and...
Yes.
Blinking?
The blinking will slow down. The expressions, like for instance, now when you're asking me a question, or when I am talking something, or when a joke is cracked or something sad happens, there are a lot of expressions on the face. Even these start slowing down. So initially it may not be, so remarkable, but then as the disease progresses, you tend to see the expressions, totally disappear. Like a mask. We typically describe it as a mask-like faces. So there are no expressions at all.
As if somebody is wearing a mask?
Exactly.
So the expression doesn't change at all?
Doesn't change, whether you're happy or sad. Like a circus clown wearing and crying inside, yeah.
Now what about dementia? How are the early signs of dementia different from what you have told us now?
No, what I was talking to you was mainly related to Parkinson, where it was more of a motor thing, movement related, where you're walking slow, getting up slow, talking slow. Whereas in dementia, it is all to do with your cognition. It is to do with your memory. It is to do with your thought process. So you tend to start forget things. Like for instance, I met you in the morning, and I've met you somewhere, I don't remember, or what I had for breakfast, or I had a conversation with somebody last evening. So in dementia, it's more of a memory issue rather than a motor issue.
But that generally happens, like on a daily basis, there are things that we tend to forget. So, is that an early sign?
Okay, yeah. No, it's not that way. Like if you want to label somebody as somebody who's has an onset of dementia, it is not that like I forget sometimes, you forget sometimes. And when some cue is given, a prompt is given, you remember, and things go on. But if it is an onset of dementia, it is a consistency. You keep forgetting things regularly. In fact, you may start forgetting your wife's name, your husband's name, your children's names, to that extent. So it's not like a normal forgetfulness which happens because of the mind being busy or not paying attention to things like that.
So memory loss, it disrupts daily life and daily functioning.
Exactly.
That's how we differentiate.
Yeah, exactly. Yeah.
Not like if I tell you I keep forgetting to order my lunch. That's okay, right?
No, that's okay. You lose a little weight. So that's fine. Yeah. Okay, but no, jokes apart, it happens once. But then you forgot to order your breakfast or your lunch, and then somebody ordered it for you. You forgot to eat it. Or you ate and you forgot you ate and you ordered again.
Oh.
That is...
No, that's not happening.
Okay, that's a red flag.
So Parkinson's and dementia are both disorders of the brain, right?
Right.
Both are neurodegenerative conditions.
Correct.
So now how do they differ in their initial presentation?
Yeah, very interesting question. Both are classified under progressive neurodegenerative disorders, which means on a daily basis it is progressing slowly at its own pace. At times it can be difficult to differentiate, but nevertheless there are certain salient features or characteristic things of each one. Like in the initial part I was talking about the initial symptoms of Parkinson and initial symptoms of dementia. So just to briefly again repeat the same thing, in dementia it's more of a cognitive thing. So so there'll be problem in memory. You'll not be able to remember things and names and places where you have been or whom you were talking to. Whereas in Parkinson, it's more of a movement related issue. Your memory will be all right, but you cannot, keep pace. You're slow. You're getting up, you're sitting down. All these things become slow. You will have tremors. Okay, so that is one of the first thing, most important thing. Then the other thing could be the age. Now, dementia by and large happens, after the 55, 60 years. We have around 60s. Whereas Parkinson can occur even in younger people. In their 30s, in their 40s, it is possible. Then when it comes to speech, the way a Parkinson patient speaks is different from a way a dementia patient speaks. Now, patient with dementia has to fumble for words. He's not able to retrieve those words. Any sentence he might pause so many times and keep searching and scanning for words.
So do you mean language also gets affected?
It gets affected.
In dementia?
It gets affected because you're not able to retrieve the data. It's there, but you don't know how to get it. So, whereas in case of Parkinson, that is not disturbed. But the way you speak, the intonation disappears.
Okay, it's slow.
It is slow and monotonous. Okay,
So-
the classical intonation which you should speak, like when I'm talking, sometimes it goes up, then it comes down.
Yeah.
In contrast to a newsreader of the earlier days, where they keep, sit with a expressionless face and, to inform
Yeah.
you, or the latest is in town, there was a bomb attack and 230 people died. There's no expression at all, because so many people
Yeah, no
died.
expression
Exactly.
on the face or in the voice.
In the voice, it just goes flat. That is Parkinson. Whereas in dementia, now you ask me a question, what's your name? My name, you either don't find the word or you fill it with the wrong word. Whatever comes to your mind. We call it confabulation. We just, whatever you find somewhere and you insert it there.
Okay, whatever, just whatever fits
Just
in.
whatever, yeah. It may not be related at all.
So now that you've spoken about the differences, are there any similarities too?
Yes, of course, yeah. Like for instance, tremors. Tremors can be found, classically in a patient with Parkinson. It can also be found in a patient who has dementia. Then the other important thing which is common in both of these is slowness. A patient with dementia is slow because he's unable to think, he's unable to plan, he's unable to, move and do whatever because of the
Confusion.
in his mind. A Parkinson patient is also slow because he wants to, but he's completely down-regulated. He cannot move properly. So slowness and tremors are two things which are found commonly to occur in both these patients. One more interesting point here is Parkinson and dementia coexist in a lot of patients. I have seen in my 36 years, and it is found. And then there are studies which say that Parkinson can eventually lead to dementia, and patients suffering from Parkinson are more prone to have dementia when compared to people who are not suffering from Parkinson.
Okay, talking about these two very scary conditions. One leads to slowness in the motor functions, and the other one leads to slowness in the thought process. I would want to know what is the role of genetics and family history in these conditions.
Well, okay, that's a question I face almost every single day. Children bring the parent, and they want the father or the mother to get treated, but along with that they want to know what risk they are at. Okay, there are a lot of studies which are being done, but nothing has been conclusively found to link any genetic pattern. But yes, if you take Parkinson's, 15% is the risk rate, of 15% of people are found to have a positive family history. So which means if somebody in the family has, then the children can have, but it is not linked. It is not that definitely you will get it, so there's no definite pattern. But then along with this, there are a lot of other factors, which contribute to making a person predisposed to either dementia or Parkinson.
Right. So if somebody in the family has a history of Parkinson's, right? So at what age should they get worried?
Well, during our initial days, when we were studying, and like if you open the textbook, you will find that Parkinson onset is generally around 65 years.
Right.
Okay, so that means they can stay put till 60 years, right?
Yeah.
Wrong. Okay. There is an entity called YOPD, young onset Parkinson's disease. Now, if you ask me, the youngest Parkinson I have treated was a 27-year-old boy.
Okay.
So you need not wait. If somebody is in the family has a positive history, diagnosed case, then you have to start taking care.
Right.
Yeah.
So you said there are some other factors as well,
Yeah.
right? So are there any lifestyle factors or any such factors which can modify the risk
Definitely.
of progression or the risk of getting these conditions?
Yes, both. Risk of onset and risk of progression. Both can be modified. Not 100%, but yes, modified.
Modified, yeah.
Yeah, the word is modified to a large extent. Lifestyle factors, the one, for instance, physical activity, okay, which you find, so difficult, especially post-COVID. People have completely couch-ridden, So, physical activity is very important. Then 2, obesity, okay, taking care of your body weight. 3, the importance of blood pressure.
Right.
Hypertension, is prone to cause that small, vascular damages in the brain, and can result in this.
Result in dementia?
Of course. There's an entity called multi-infarct dementia or vascular dementia. Okay, and I'm a boxer. You must have heard of Muhammad Ali. Okay,
Yes.
Now he developed from what we call as punch drunk syndrome. That gets by repeated punches on the head, where there's micro trauma happening to the small vessels in the brain. So hypertension, diabetes, smoking and alcohol, and of course, a very, very healthy diet, a balanced diet, and there are a lot of things which are being said about what kind of diet.
So a bad diet can lead to these
a
conditions.
bad brain.
A bad brain.
Bad life. Yeah.
Right.
Yeah. So these factors, 1, can delay the onset, and 2, even after the disease. I have patients whom I'm treating from the early 90s. From the early 90s, they were in stage 1. They are still in stage 1. And just mild tremors and a little bit of slowness, and I've just put her on very strict nutrition, physical activity, taking care of all the other parameters. She is not on any medication so far.
Wow.
So, yeah, okay, this is one which I just remembered now. She's been following me wherever I am, so it can modify, definitely, yeah. And then we have scores of patients where with just modification of these things, we have been able to maintain them at that stage, or let it go slow.
So you said smoking, alcohol consumption, diabetes, obesity, lack of physical activity, and a bad diet, other risk factors. Is there anything else?
Yes, there's one more very important thing which has been found. People who have low cognitive stimulation. Okay, now let me elaborate on that. Sounds a little too high for anyone's cognition. So, where people do not engage in a lot of mental activities, these people are prone. They stand at a higher risk to develop these disorders. And also people who are loners, people who do not have a big social circle, which can work either way, but people who live in isolation, they are also more prone to develop these disorders.
Yeah, they don't meet people, other people often. They're socially isolated.
Exactly.
So
they're socially, it all depends on how you look at it. Now somebody is socially isolated, there's no exchange of ideas, no exchange of thoughts. Now you're sitting 4 people, there's a lot of conversation happening, so you're stimulating your cells.
Right.
The cells are active, and the more you must have heard that old saying, the more you use the knife, the sharper it becomes. So the more you use your brain, the sharper it becomes.
Yeah.
So you're engaging, having discussion, thought process, exchange of ideas. So being in a group, man is a social animal, and that's how he or she is supposed to be. So yes, it's
so
very
that's
important. Yeah.
how even healthy aging is. That's how it's said that you age in a certain way if you spend a life alone, and if you're surrounded by a group of friends and family, and that's how, if your aging years are, you tend to age well.
Exactly. And where people have communities, where there's a network, people, it's very important. It's very, very important. Social network, being together helps, even if there is an onset, you tend to manage it over a longer period of time, in contrast to somebody who is alone. Everything magnifies, and tends to set in faster.
So are there any stages for the two diseases that we're talking about, Parkinson's and dementia? So talking about Parkinson's first, are there any stages which can classify the disease, and what are the early stages like?
Right. See, in medicine, when you come to, most of the diseases, we have stages, by which we know where is the patient right now and what can we predict in the next few years. So in Parkinson, if you look at it, Hen and Yar, were the two people who classified Parkinson way back in 1967. Yeah, 1967. They classified Parkinson into 5 stages. Stage 1, 2, 3, 4, 5.
Right.
Yeah. And stage 1 and 2 are considered to be the initial ones or the mild ones. Right. Then there's an overlap. 2 and 3 come in the moderate, and 4 and 5 are the late stage or the advanced stage.
Okay, so now what is it in the early stages? Symptoms are seen? Are they noticeable?
Yes, symptoms are seen, but like stage 1, majority of cases, in fact, I don't know, at Plexus we get hundreds and thousands of cases of Parkinson, and the common thing which I keep hearing from everyone is that 3 years, 4 years down the line, the case was diagnosed, some doctor picked up, because initial stages are very, very mild. Like I was mentioning in the initial part of the podcast, you will have mild tremors, mild slowness, mild, very mild stiffness, which could be attributed to, most commonly attributed fact which you must be hearing, the mental health, stress, worry. 2, it could be, generally people attribute it to fatigue. You're overworked, you're tired, or, these kind of things. And a lot of people start vitamin B12 is the commonest thing which everyone takes. In the morning I had 2 other patients who were saying the same thing. For 2 years they were on supplements. And then later the symptoms became a little more pronounced.
Okay, what about dementia? Are there any stages as well?
Yes, in dementia we have 7 stages. The first 3 are considered to be the mild ones, and 4, 5 are in the mid segment, the moderate ones, and then 6 and 7 are very severe.
7 stages.
7 stages, yes.
Okay, so how are the early stages there?
In dementia, early stages are mild memory loss, forgetting what you had in the morning, whom you met, while you're talking, forgetting what you have to say, skipping a few words here and there, and forgetting where you kept the key, forgetting what you had for lunch or whom you met, which could not be very significant, and as it goes on, becomes pronounced, becomes consistent, and then you enter the subsequent stage.
Okay, and what is the end stage like? I'm curious to know.
Forgotten.
Completely totally forgotten?
Yes. Okay. End stage is
like loss of identity?
Loss of identity, of course. Recently here, we have had people at Plexus, at very high profile people. I cannot name what kind of profiles also. Such high profile people abusing, spitting, and talking nonsense. They don't know who they are, they don't know who their family is, total irrational behavior. The end stage is a terrible stage, and they don't know what they're doing.
Right.
Yeah. A complete loss. They have no clue who they are, where they are, their place and person, everything is gone. That's the saddest part,
right,
of this disease.
So, how critical is early diagnosis for effective management of these conditions?
Well, you have heard of that common phrase, a stitch in time saves 9. I keep talking about this to all the patients whom I meet. Anything, early intervention is the key for anything in life. So, in Parkinson and dementia, now, like I was telling you, now I had a patient way back, early symptoms, diagnosed, modified the lifestyle, showed them what all exercises to do, what kind of diet they should eat. Patient is maintaining. And now here at Plexus again, we have had I don't know how many scores of patients who have come in the initial stage, managed very, very conservatively, educated the family members, educated the patient, and they're maintaining, 4 years, 5 years, 6 years, things are going smooth so far. So early intervention is critical, because once the neurons damage, you can't do anything.
Right.
It's gone.
So in the first 2 stages, you're able to halt the progression?
Yes, in a lot of cases. Nothing is absolute in this life,
Right.
But then yes, to a large number of patients, be it Parkinson or dementia, we can stop, not only stop, in a lot of cases we have been able to bring them back to a certain extent.
Okay.
Which is
like bring them back from stage 3
exactly,
to 2.
Exactly. We have had patients where they've come in stage 1 or stage 2 of either Parkinson or dementia, modification of all these things, they're maintaining their life as if nothing has happened.
A good quality of life.
Good quality of life, that's what we are looking at, quality. So yes, it is possible, and diagnosis is very important at that initial stage. I keep stressing to everybody, when you have anything which is not going right, do not sit and wait hoping that tomorrow will be better. No, you may never get tomorrow. It is today, just today. You will have to go get a proper diagnosis from a proper specialist and get things sorted out.
Yeah, I think that's very important, to go to the right kind of doctor.
Exactly. Yeah, very, very, very important.
Right, because that's the only reason why early diagnosis, can happen. If you see the right doctor, if you see the right specialist.
Yes.
So have you come across such instances where diagnosis has been delayed and the patient has gone from stage 1 to 2 to 3 and still struggling to find the diagnosis?
Thousands of cases, not hundreds.
That's very sad.
Yes. See, one thing is now it is only a jeweler knows what's a diamond. Okay. Similarly, now an orthopedic surgeon knows something is wrong with the joint. A neurologist may not be able to identify that. Right? A cardiologist knows what's wrong with the heart.
Mm-hmm.
He will not be able to tell you what's wrong with, say, the ligaments. Yeah. So going to the right specialist who can pick it up and say, hey guy, this is not fatigue. This looks like Parkinson. Let's investigate. And almost in a week, I don't know how many I keep getting, where people say, for 10 years we were going there, we were taking this kind of medicine, nothing happened. Then finally, somebody told us, why don't you go to this specialist? They went to the right specialist, got the diagnosis, but unfortunately, they were already in stage 3 or 4.
Okay.
So yeah, that's a very important thing. Go to the right specialist.
That's a neurologist.
That's a neurologist.
Not
yes.
a neurosurgeon.
Not a neurosurgeon. Yeah, not a neurosurgeon. Go to a neurologist, and if there's a doubt, then you could take a second opinion. There's nothing wrong in that.
Yeah.
If somebody diagnoses you as Parkinson and you're not very happy,
you don't want to accept that.
Exactly. You want to deny it. Then take a second opinion. Okay, take a third opinion. There are diagnostic things by which you can do that and confirm it. We are in an era where things are available. not that 40, 50, 60 years back where, people would just look at your pulse and diagnose whether somebody is pregnant or not. Okay, so now, you must have seen that, so they look at the sample of urine and make their own diagnosis, but that was a different science which they had. But now we can say which part of the brain is not functioning, and after the treatment how that part changes and starts becoming better, starts becoming functional. So go to the right specialist, very important point.
Yeah. So just out of curiosity, in Parkinson's, is there something where you can actually see that part of the brain which is not functioning, or is there something like that?
Yes. Okay, see, our brain is a huge structure, okay, and it's so complicated, I doubt if any human can ever understand it completely. In the brain, there is something called the basal ganglia. This is a network of a few cells there. They are the ones which are responsible for our movement. Okay, so if those are functional and they are doing their job properly, then our movement is perfect. If they become lazy and they are not doing their work, the person becomes lazy. Although he doesn't want to, his movement becomes slow.
Okay, so we can actually see that.
You can see that on a scan. There are specialized scans for that, where you can point it out and say, look, this is where the problem is, which is easily identifiable.
That's very interesting.
Exactly. I have so many cases now, where I get these people who come with tremors. Okay, in fact, I have made a video on tremors and it's there on our channel, where they think they have Parkinson.
And it's not Parkinson.
It is not Parkinson. And it's very difficult sometimes for a patient to convince that it is not Parkinson. He wants to believe it's Parkinson the other way.
Why?
Yeah. Well, there is a set of people, who, especially nowadays, Google.
They want to be labeled?
No, they go on Google. And they see, if you have tremors, then you're Parkinson. Then Parkinson, when you are in stage 4, 5, you'll be bedridden.
Oh, Dr. Google.
Dr. Google, Google University, right? So, and then they keep on. And there are some people who I have had who have been started on medication also. So then one scan and, you're either this way or that way. So, we are in a, God's grace, we're at a time where we can point out and say what's wrong where and why.
Right.
And we can set it right to a large extent.
So are there any such misconceptions around Parkinson's and dementia, that can mislead?
Yes, there are several misconceptions about dementia as well, which you must have heard. One is reduce your memory. There's memory impairment, that means
you're demented.
Okay, it's a common phrase.
It's a slang,
can forget. It's a slang. So that is one misconception. So
memory impairment is not equal
to dementia. It can be because of several other factors. Two, again, age related, which also is not true, because we have an entity called presenile dementia.
Oh, here also. Okay.
Yes. Okay. Right. Then the other misconception which commonly is believed is that dementia is equal to violence. People who are demented are violent, aggressive, you're unable to control them, which is not true. Not all patients with dementia turn up to be violent or show aggression. They can be very, sulking, quiet, sad patients with dementia also. Then we also have this fact that once a person gets dementia, his life is gone.
Yeah.
Okay, nothing can be done, which is so sad, especially in the initial years when I came down. I used to see some of these places where the children have just dumped the parents in a center which I'm sorry to say, but where you can't even enter, because the concept people have is it has dementia, nothing can be done. So every month you pay this much, they will feed and take care of him until whatever has to happen, which is not true. If taken care properly and guided properly and managed, there's a program which we at Plexus do for these people. They can lead not a very good life, but like you were mentioning that at some point of time, a quality life. They can lead a better life. It is possible. Yeah.
Right.
And there's a lot of misconceptions about genetics as well, which I answered in one of my previous questions.
Okay, so can dementia also be seen on a scan?
Dementia, yes, it can be seen on a scan.
Like what do you see?
Like see, for instance, now if you do an MRI scan, magnetic resonance imaging, you can see what we call as cerebral atrophy. Okay, which in common language, to make people understand, we say the brain is shrinking. Okay, that's what is commonly seen. Yeah, and in certain types of dementia, you might find tiny clots, small clots scattered all over the brain. So these are the common findings. There are quite a few, but yes, on a scan we can see certain changes in dementia.
So after we have spoken so much about the risk factors and the signs and symptoms and the misconceptions around these conditions, what about the treatment? Now, are there any current advancements in the treatment options for these conditions?
Yeah. Now both these disorders, like all other diseases, research is going on. Now, when it comes to Parkinson and dementia, billions of dollars are being spent to find new treatment methods, because as of now, we have not found a cure for both of these diseases. Now, just to mention, for dementia, there are 141 drugs which are undergoing trials. You can imagine. Okay, and I think 23, there was just one drug which got approved, and there's one more drug which is almost, it has completed the trials. So in dementia, that's a progress. And in Parkinson, again, there are a lot of drugs, lots, some has completed phase 1, 2, 3, and things are happening, but we have not yet found anything conclusive. Things are happening now. Besides the medication, in Parkinson we have something called focused ultrasound therapy. We have deep brain stimulation just before the gene therapy, and something which is emerging as a new champion for both these disorders is gene therapy and cell therapy. Regenerative medicine is something which is making very good progress, very good advances, and I think the results are found to be good in both these disorders.
Okay, so regenerative medicine.
Yeah.
That sounds hopeful.
Yes, you're going to regenerate. Sounds magical. Yeah. So yeah. We are just hoping, and it does, and it is doing. Whatever studies are being done all over, and whatever results have been emerging, there are very positive results which are coming in both the conditions, be it Parkinson and dementia.
Irrespective of the stage.
Irrespective of the stage, but yes, earlier stage,
the
better result. Yeah. You're in stage 1, then you can come to 1. You're in stage 5, then come back to either 4 or 3 if you're very lucky.
So now we have spoken about the treatment options. Now, apart from the treatment, what else can the caregivers do to better support patients with these conditions?
Yeah. Interesting. Very interesting question, and this is something which is very close to my heart. Because generally what happens is what you mentioned. One of our dear ones, parent, father, mother, somebody developed Parkinson or dementia, or the doctor, the best specialist in town, number 1 doctor, take the medicine, keep a caretaker, give the medicine, I've done my duty, God will send me to heaven. No, not at all. That is one part of the treatment. There is so much more which the caregiver needs to give to the patient. Okay, like the basics, brushing, hygiene, bathing them, feeding them will be done. But then what happens most of the time, what I have seen is, we tend to forget that this is a human being who did so much for me all these years. Today I am what I am because of all that, and they're just a body there of flesh and bones, without any soul, without any feelings, without any emotions. This is forgotten. So here what I want people to understand is that involve them in every single thing. Like what? One, take them around. When I see somebody, coming to a mall and, the old father or grandfather is on a wheelchair, that I feel so good. They brought them to a mall, they're taking them to a movie, they're taking them for whatever, some amusement kind of stuff. So keep them involved in activities. Keep them involved in, like you're watching an interesting movie. Bring them there. Say, come dad, let's watch this movie. Remember this movie, how we had watched when I was small, you had shown me this. Or any family matter. He or she may not be able to give their opinion, but keep them in the loop. Tell them, we are going to make this decision. We are going to move house. We are going to invest somewhere. We are going to buy some property. It could be a simple thing. What do you want to have for dinner? Let's cook this for this festival. Keep them involved. These things go a long way in bringing the morale of the person and lighting that desire for him or her to live again. So these are very important things which the caregiver should involve in their planning when they're taking care of any of their relative suffering from Parkinson or dementia. Now besides this, the other important thing is even the caregiver should take care of himself or herself.
Yeah.
There are a lot of ways, like I keep telling my patients, you can have shifts. You can keep some time slots, I will do at this time, you will do at this time, or you take care for this week, so many days, or, something, so that one person does not get burdened and want to get rid of his father or mother. So the duties are split.
Reduce the caregiver burden.
So that they also have time to recharge. Because see, one is, father or mother or aunt, uncle, whoever is suffering, and you're taking care of them, you are also undergoing severe mental turmoil. It's not a joke.
Easy, yeah.
It's not easy. See, to take care of a child is easy. When a baby is newborn, in 1 year he's going to run. 2 years he's going to happen.
It's temporary.
3 years he's going to go to school. Here you're seeing something. It's like holding sand in your fist. It's just going. It's just going. It's a terrible feeling. So even the caregiver should have a network. Find methods to unwind. Like in my previous podcast I was mentioning, the taps. Find certain taps to relieve that stress, and maybe have a network of people suffering from similar disease. That goes a long way.
Yeah, join a support group,
where my dad is suffering from this, you're somebody suffering from that, so we share.
Nowadays through social media it's all possible.
Exactly. Now see, at Plexus here now, almost every disease, they have a group, WhatsApp group.
Yeah.
The spinal cord injury has Parkinson, autism, CPs, they all have the groups and they share. They come back and tell me, for that patient you had advised that, so can we do this also to our child or to our parents?
Yeah, that's so nice.
It's amazing, and it lightens. Sharing your burden, exactly. And feel lighter and say, okay, there are so many other people in a similar thing. In fact,
you don't feel alone.
You're sharing it, and when you see somebody suffering more, although you're suffering, but you offer your shoulder to them, it's a beautiful feeling.
Maybe you also start counting your blessings.
Always, like patients, when they sit in the reception lobby, they look at the other patients and they come inside, and first thing they say is that we come here and we enter inside and say, thank God we walked on our 2 legs and came inside. It is.
So what is the impact of mental health on these conditions, on the progression of these conditions, Parkinson's and dementia?
Huge. I had mentioned this in my TED talk, which I did sometime last year in Jaipur. Mental health plays a very, very, very important part in most of the things, but here, especially Parkinson's and dementia. In what way? Like, for instance, now somebody who has developed Parkinson, he's mentally strong. He hasn't gone into a stage of depression. He's not very anxious as what's going to happen. He has accepted it mentally and says, okay, fine, let me try to fight it out. One, he will take medication at proper time. Two, he will follow the regime, whatever has been given. He'll follow a strict lifestyle. He'll try his best because he's positive. He wants a positive outcome. There are lot of patients whom I have seen, and where here, especially at plexus, where children bring their father or mother who is having either Parkinson or dementia. They're very keen. They want their parents to become all right. But the parents don't want to. They're just lying down. We literally have to force them, do this, do that. No, they don't want to, because they have lost the battle even before it started. So if they have that resilience, if they have that strong mental power, okay, yes, I want to fight this, they fight. In fact, one of the best example I keep giving to most of my patients was, one 87-year-old man who came. He was admitted in the ICU for almost 4 to 5 months. And the children kept on calling me, please, we want to come down to Bangalore. I said, no, I cannot take him. But then finally they came. We started the treatment, and this man, the way he bounced back, and he was a different,
At 87.
At 87. In my department, my therapists were wondering as to what should we do now with him. He's doing everything which we in our 20s and 30s can't do.
Oh, that's unimaginable.
It is, it's amazing. Like right now I have, he gifted me a peacock about a month back. This young man, I call him, amazing. He does, I think, about 22 Surya Namaskars every day. Diagnosed with Parkinson's stage 3 going on to 4. He underwent treatment here, and now there's no looking back at all. He got his own cycle. He goes cycling all over. So mental health plays a huge importance. Your will to become better, that mental fortitude and the resilience. So the same applies to dementia as well. In following your day-to-day routine and doing whatever has been recommended, you bounce back, literally bounce back. So mental health is in fact a huge wealth. If you have it, then even if there's a disease, we're degenerative, we're progressive, we can fight it out.
Okay, I want to ask you something on a personal note. Now, there are a lot of older people in my family. I'm the youngest, so there are a lot of old people, grandparents, and people in their 70s and 80s. Now they are slow. They forget things. They sometimes, get very angry also. So, how do we differentiate between early signs of these conditions versus normal aging?
Okay. Good question. Okay. See, if you have followed the discussion, what we've been having on dementia. One, in normal aging, you have forgotten something which happened last year. Or when did COVID happen? Was it 20 or was it 21? Was it, this is normal aging. Okay. In dementia, yesterday what happened? Right? When was Holi? That is dementia. Something which happened recent, you forget. Whereas in normal aging, something which happened over a period of time, maybe 6 months, 9 months, 1 year down the line. So that is number one.
So in dementia, basically you lose track of time?
You lose track of time, and you're not able to register anything there. Nothing is being saved there. the recent memory is gone. It just doesn't come. But whereas in normal aging, it's there. You have to search, type the right keyword, then it pops up.
Right.
Yeah. Then the second one would be in normal aging, like you forget you met someone about 6 months back in a conference or in a function or in a meeting or whatever. Whereas in dementia, you forget the name of your son. You forget the name of your wife.
Yeah, known people.
Your people. Your family members. As in normal aging, it's an acquaintance. Somebody whom you had met and...
Yeah.
In normal aging, when you're talking, you may forget one word here and there. You're just trying to scan for that word. You fumble a little. You find a synonym or something, replace that word and continue talking. Or, I'm not getting that word, and somebody prompts and that's it. You continue talking. Whereas in dementia, there's no output at all. You're pressing, you enter, the screen is blank. Okay, nothing comes out there.
No words.
You're not able to retrieve.
Language is forgotten.
Completely forgotten. I've had certain. There was a patient who was a poet. Beautiful poetry he would do. Now he's literally speechless.
Yeah.
Cannot speak. Cannot come up with that poetry or poems or whatever he used to do earlier. These are some of the important differences between normal aging and dementia.
And how about Parkinson's disease? Between early signs of Parkinson's and normal aging?
No, both the patients will have slowness. Okay, bradykinesia is there in Parkinson, and a normal person who is aged will also be slow. Right. But there is a very, very typical gait pattern which is there in Parkinson, which is known as a shuffling gait.
What's gait?
The style of walk. The way. I'm sorry. Okay. The way a person walks, right? So when a person is walking, it is as if you must have seen how you shuffle the pack of cards. One foot moves. You as if your feet are glued to the ground, which will not be there in normal aging. Okay, he's just slow.
Yeah.
2, there is something called as freezing, which happens in Parkinson's, where your feet are literally glued. You are unable to lift that. It's like
frozen. You're frozen.
Like you're frozen. You press the ignition. You're just pressing. It's not firing at all. That's the same thing which happens. The person wants to move, but he's not moving.
Not able to initiate
at all. And once you initiate, you're not able to stop.
Oh, so any change in movement is not happening.
Happening in Parkinson. Whereas in normal aging, he is just slow.
Yeah.
He's not freezing, he's not shuffling, he's not stuck. He's constantly slow. And the third one is the balance. Because of these freezing episodes, because of this shuffling, the person is not able to, like I was talking to you now, when he starts walking, he's not able to stop. He's not able to take a sudden turn. He's not able to move this way, that way. There's a increased frequency of fall here. Whereas a person who is slow because of normal aging, he knows how to move around. He does not have, he will take a larger radius and then turn. And then the frequency of fall is much less here when compared to Parkinson.
Okay, so falls are occasional
and much more frequent in Parkinson.
Okay. And what about speech? Is there anything to do with speech also? How is the speech different?
See, the speech in both the conditions will be low volume. Okay, normally, a person who is aged normally may not be able to scream, shout and talk in a very high-pitched sound. But then there will be the normal intonations which are there will be present. Okay, you may have to go closer to him to listen to what he's talking.
Only the volume will change.
Exactly. Yeah. Whereas in Parkinson, the intonation is gone. It's a flat
the entire
speech.
Pattern changes.
It's just one tone in which he'll be talking. So that's a huge difference between Parkinson and normal aging.
So earlier in our discussion, you have spoken about lifestyle factors, and there you have mentioned about bad diet, right? So now I would want to know, how does diet influence these neurodegenerative conditions?
Right. If you go on the internet, you'll go mad.
Yeah.
Exactly. You don't know
There's
what should
so
I.
much.
There's so much, and the kind of questions which patients ask me, they find some exotic fruit which is grown in some part of Africa somewhere. Will that improve my memory? So there's so much spoken about, but there are a lot of diets. One very famous diet, or most spoken about diet, is the Mediterranean diet, which is rich in fruits, vegetables, olive oil, potato, beans, proteins, and that kind of thing. But by and large, what is the consensus, if you ask me, to give something which is simple to follow, which a common man can easily do, is to have a very balanced diet, which we studied when we were small in our school, and we have forgotten, which we don't like to
carbs,
do
proteins, fats.
Okay. Have a right amount of balance. But yes, the teachers used to tell us, green leafy vegetables, which children, the parents have to hide them in some kind of stuffing and then feed them. Right? So green leafy vegetables are very, very important to protect your brain and to improve your brain. Then we have nuts. In nuts, especially walnut. Okay, almonds, like you must have heard, somebody's like I keep telling everyone, just eat almonds and come back tomorrow. So it's common phrase. So nuts are good. That's a brain food. Then we have berries. Okay, which again are very rich in antioxidants, and they also help the
all these
protection.
Blueberries and strawberries.
Very, very good. Then in proteins, if you look at the fish, especially the fatty fish, like the salmon, fish is very, very, very good. It's not only white meat and helps in cholesterol, triglyceride, but also helps protect your neurons. So you have green leafy vegetables, you have nuts,
berries.
Then you have berries, then you have fish, and some amount of protein and some amount of cereal in the right proportion. What is important here, to have the right balance, number one. Number two, to have it consistently. And while I'm talking about what we should take, I think I should also mention what should not be taken. Most important thing is alcohol. Okay, that is deleterious for both of these conditions. Okay, so, and of course, smoking. So I don't know if that's part of diet or part of lifestyle, but it should be avoided. Yeah.
What about dairy? What about red meat?
Dairy is known to have a deleterious effect.
Oh.
Yeah. On the all neurodegenerative disorders.
Okay.
Yes. So we strictly, tell all the patients to avoid dairy products completely.
Red meat?
Red meat, of course. Yeah. Red meat also. So have white meat, have more of salmon or fish, have nuts, have vegetables, and remember to eat them.
So as we come to the last part of this podcast, I would like to conclude with a question. What support systems are crucial for patients and families who are diagnosed with Parkinson's and dementia?
You need a complete network. Like I do here at Plexus. I call it a holistic 360-degree program. That's exactly what is needed here. Now, what does it comprise of? One, your neurologist, the doctor who specializes in diseases of the brain. You should have a regular follow-up and connection with him or her. Two, a proper rehab team. A rehab team includes one, a physical therapist, occupational therapist, speech and swallowing therapist, a cognitive rehabilitation specialist. All these people are involved. It's not just doing some exercise. No, there is lot of rehab which a person needs, and the person needs to be in constant touch with the rehab team. Then 3, a lifestyle expert, which includes not only your physical exercises depending on your body, your age, your fitness level, and keeping all these in mind, somebody who prescribes the right amount and right kind of exercise. For not everyone, the same exercise does not fit or suit everyone. A patient with dementia may need something else, patient with Parkinson stage 3 might need something else, plus a nutritionist, somebody who can plan your intake, your food properly. And besides this, to be involved, like I was talking about this sometime earlier, to enroll yourself in a support group or have your own community. Have community, whatever disease, either the patient community or the caretaker community, where you can share each one's experiences, joys and sorrows both. But this network is very vital, very vital. The reason I am emphasizing on this is where I've seen patients, they come, the diagnosis is made, the plan is made, the therapy is done, everything is done. The patient has improved. The person who had come on a wheelchair is now walking. The person goes back and starts doing some kind of vague exercises from YouTube. Because now internet is a university. They find solution for all the problems on the internet. They click exercise for Parkinson. That's an exercise for somebody else, not me or not you or not him. So these people, after completion of the program, they are lost, and they get back to me a year later, 2 years later, and they say, okay, look, we had done treatment, this is not happening. Look guys, you were lost. I don't even know who you are. Are you following all these points? 1, 2, 3, 4, 5. Like this morning I had a follow-up. I was asking the person, are you eating these things? He said, no sir. I said, are you doing these exercises? No sir. One neighbor comes and does some little massage for me and goes. So that is not, this is science. This is science. Each patient, every therapy, like here what I do is customized.
Can you tell us a little more about it? Like you mentioned, a complete rehab team is the word that you used, and you just didn't say physiotherapy.
No, I didn't say physiotherapy. I said physical therapy.
So can you shed some light on all these professions that you have named here? What is the role of each one in Parkinson's disease or dementia?
Exactly. See, what happens is the layman, person, a non-medical person, equates anything which is done in rehab to physiotherapy. Physiotherapy or physical therapy is a science that is done, it's part of a rehabilitation program. Now, in physical therapy, what do? Strengthening is done, removing the tone, removing the stiffness. These are the things which are done, to regain your strength back. Okay, that is done in physical therapy. Now, what is occupational therapy? Like, for example, now I've got my strength back, but I want to, hold this cup, pour tea in that and drink it. That occupational therapist does. The functioning, how do I button my shirt? How do I do my day-to-day activities? Giving strength is a physical therapy. Giving function to that is the occupation. Like I've got strength, I can walk, but balance is given by occupational therapist, else you'll fall. Right? That's the role of an occupational therapist. Speech. Now you have done all this, but still the person is unable to talk properly. A speech therapist improves the speech quality.
That's an entirely different system.
A physiotherapist can't do that. A neurologist can't do that. An oncologist can't do that. Right. Each one has their own area of expertise. So for speech, a speech therapist is needed. Somebody has issues in swallowing. there's a different part of speech therapy, speech and swallowing therapy, where there's a therapist who specializes only in the swallowing techniques. Okay. Now, besides all this, we need a cognitive therapy, somebody who specializes in cognitive rehabilitation, where you are wiring those thoughts. How do I link them together? I don't know if you're imagining what I'm seeing. Memory, thinking, thought process, comprehension, execution, language. See, language is not from the mouth. It starts from here. Okay, so that a cognitive rehabilitation specialist does. Now, along with that, you also need some amount of counseling. A psychotherapist or a clinical psychologist who does counseling of not only the patient but also the caretaker.
Caregivers, yeah.
Okay, so this forms the rehabilitation, which at Plexus, this is what I do for all my patients, and we tailor make it. One code does not fit everybody.
Yeah.
Each one, there might be a difference of 5% or 7%, but there is a difference. So everything has to be individualized. We cannot, one size does not fit all here.
So thank you for a very insightful conversation. It was a great conversation on Parkinson's disease and dementia. I'm sure everybody has learnt a lot, and there's some message for everybody in this video, whether it is a patient with Parkinson's or dementia, or a caretaker, or even a therapist who is dealing with these conditions. So thank you so much, Dr. Naeem, and we'll see you in the next podcast.
I hope you don't forget and remember everything. Well, guys, so Dr. Naeem Sadiq from Plexus here on the channel Dr. Brainstem signing off, and see you in the next podcast. If you have any questions, you can always post them and I will answer those. And if there are any specific topics you would like me to cover pertaining to the brain, mind, or anything to do with mental health, you can always share your comments and ideas, and I will try to have a talk or a podcast on those. So till then, bye bye.